Okay,
yeah, we can
got
see.
one.
Yes.
Okay, yes,
Yes,
great.
restart. Yes.
Okay. And also, do you see mine now?
Okay. So sequence is probably Elena is the first because we can see a half slide.
So who is going to present, myself or Elena? Just
Elena.
let us know.
Elena is the first. Okay.
Okay, great.
Elena,
Okay.
go ahead. Yeah, please go ahead.
Okay, thank you. First, I would like to thank all organizers who invite me with our data and thoughts about some rare and not so rare genetic variants at this webinar. And today I'm going to speak about some genetic variants, very important, very common, and it's not very easy to interpret. Can I change the slide? How can I? The role of genetic testing in long QT syndrome now is quite high. It's a very common disease and it can be found in population with a prevalence of about 1 per 2,500 individuals everywhere. And if untreated, 10 years mortality for this patient is about 50%. For now, the impact of genetic testing for diagnosis confirmation, for prognosis estimation, and for decision making for therapeutic option is very high. And according to recently published guideline, expert consensus statement on the genetic testing for cardiac diseases, the routine genetic testing expect DNA diagnostics of 5 common genes, but if you have an opportunity like or possibility facilities for whole exome testing, it can be made directly with exome testing. Next, please, because I think that Gary pressed the button. The normal workflow of genetic diagnosis is presented here. Everything got started from genetic counseling. Then if you find genetic testing appropriate and important for family, you can perform NGS, new generation sequencing, and you can produce a lot of genetic data very quickly, relatively cheap, but there are some artifacts, and any finding you get from NGS approach, you have to confirm by capillary Sanger resequencing. And next step is very important, data analysis. You have to understand what did you see on your sequence, and you have to choose right variant to discuss with family. Sometimes it's not so easy because normally from whole exome sequencing, we take from 80 up to 180,000 genetic variants. Sometimes you need some additional functional studies and data reanalysis, and the ring was closed by genetic counseling again, with family discussing the result of genetic testing. Next, please. But the bottleneck of genetic analysis is data analysis and interpretation, because clinical significance of particular variant is particular dot in the continuum from benign genetic variant with no clinical consequence up to pathogenic real cause of inherited disease. And it's not very easy to choose what part of this continuum you have to choose. Next, please. Right now, we have five classes of pathogenicity we can prescribe for any genetic variant, starting from benign up to pathogenic. And actually, the most common finding in whole exome sequencing for now is variants of uncertain significance. Next, please. That's why it is highly recommended that interpretation of the variant requires special experience and expertise. It's quite difficult to, let's say, work out cancer genetics and then go directly to cardiogenetics or pulmonary genetics or any other. Right now, we have very high level of specialization even inside genetic disciplines. Next, please. And to facilitate this process and to make this process, let's say, standard, we got very nice document in 2015, the first standards and guideline for interpretation of sequence variants. It was very common and very good document, but clinical interpretation was not disease or gene specific. We got very good tool, but very general one. And right now, can you press a couple of times, please? Yes, and right now we move toward gene-specific and disease, and one more time, and disease-specific interpretation of genetic variants. Right now, we have more than 10 different guidelines oriented on specific diagnoses or even specific gene, like in 2018, we got a special update for variant interpretation in beta-myosin heavy chain gene. Next slide, please. To estimate pathogenicity correctly, there are 22 different criteria. And right now, like cardiologists have own virtual calculator for sudden cardiac death risk estimation. In genetics, we also have several online and not online tools to facilitate this process and to make it as fast as possible. Next, please. All these variants are good enough, but still not ideal. And actually, the variant of unknown clinical significance, it's a class 3, is a nightmare of geneticists. We can do almost nothing with this variant. We cannot confirm diagnosis, exclude diagnosis, or do whatever except segregation analysis, just keeping hope that in big family we can find or exclude segregation of given variant with disease. But the most important, I mean, clinically important finding if are variants of 5th and 4th class of pathogenicity. But there are a lot of things we cannot do. For example, we cannot exclude of diagnosis with genetic negative result. There is no exclusion power of genetic test, but right now we have a special recommendation. I mean, a special recommendation to estimation different criteria, including population criteria, to make a correct classification of our variant. Next, please. According to current guideline, the very current guideline how to interpret variant for long QT syndrome and Brugada syndrome, we got a special estimation for and special frequency threshold for rare variants. And now everything what is more common is 1 per 10 in minus 3 stepping, yeah, is benign. This population frequency, what's marked by green, what is higher is benign. It's standalone criteria. If you find something, it's certainly neutral for health. And if you have something with red, you see red threshold or less, it's accepted for clinically significant variants. And next, please. But even three years ago, we got a very interesting paper discussing very many variants, at least 4 variants, quite common in population, and the prevalence exactly between 2 borders, between benign, clearly benign, and between PM2 criteria, too rare. And there are many variants here. I present only some of these variants, which were shown to have functional consequencing in cellular experiment, in cellular electrophysiology, and they represented in disease cohort with much higher frequency than in general population, but still the prevalence of this variant does not fit with criteria of PM2. So these variants are not rare enough to be interpreted as pathogenic. And actually for me, as I am clinical geneticist, it's quite difficult because we do have such a variant in our clinical cohort, but it's extremely difficult to deal with such a variant in clinical reality. Can you press next one? We performed data analysis of 226 patients who underwent genetic counseling and testing. In our hands, it was whole exome sequencing based on clinical diagnosis of long QT syndrome. These patients came to us from different clinics. And we had a look how many such a not rare and not common variants do we have. And finally, we got about 20% of our clinical cohort carrying such a variant we cannot, let's say, interpret unequivocally. And the most common variant was rare polymorphism or functional polymorphism or mild mutation, R176W. It's the most common variant. Next, please. And we found 19 unrelated probands and 34 family members carriers of this variant, and in 3 cases our genotype positive probands had additional pathogenic or likely pathogenic variant in 3 or 4 main genes related to long QT syndrome. And if you see here the mean QTC interval for this variant only carriers was higher than normal, but still less than it requires for diagnosis according to Schwartz score. And if we had this variant in combination with a second hit, we had really severe clinical phenotype with syncope, with sudden cardiac death, and with a mean QTC prolongation up to 515 milliseconds. And the mean age of the first appointment was 17 years old, but the range was from 7 up to 42 years old. And QTC prolongation was unmasked by intensive sport in about half of this proband, and we really think that special condition, external condition like lifestyle, like intensive sport may be a provoking factor, like QT prolonging drugs may be provoking factors for such a mild variants. In family members, we found 2 cases of cardiac death, and only 4 family members carrying evident diagnosis. It was only in 10%, bit more than 10%. So the penetrance of this variant is really low. It's really very common variant with low penetrance, and it does not fit criteria of real pathogenicity of 5th or 4th class of pathogenicity. So you somehow you're obliged to qualify it like class 3 variant of uncertain clinical significance. And it's very difficult and it's really wrong, because if you have variant of unknown clinical significance, you cannot do anything. You cannot really consult patient. You cannot give any recommendation. It's clinically non-actionable class. And another problem, if you get if you qualify such a variant is a variant of unknown clinical significance, you're not always able to recruit the family members to perform cascade familial screening, and also prescribe any recommendation about physical activity, about prolonging drugs, and so on. So it's common, it's significant, but current recommendation does not allow us to qualify it as a high class of pathogenicity. Next slide, please. In 2 cases, we got this variant is as an incident finding in patient with Brugada-like pattern. And for me, it was a bit strange that only after identification of this variant, cardiologist just remeasured QTC interval, and it was found 480. What is actually important for diagnosis, it's already clinical diagnosis of long QT syndrome for female, and but clinicians were for some reason focused only on Brugada pattern. And next slide, please. And another example of the same situation when real QTC measurement were performed only after genetic analysis. We did not find anything related to Brugada syndrome, only this finding. And after positive genetic test, QTC was remeasured, and it was found too long for patients, for this male sportsman. Next one, please. And here another variant, also with the same story, too common to be classified with a high score, but clinically significant with a lot of experiments published. It was shown that this variant decreased potassium channel, and in this asymptomatic family, whole family were found only after DNA diagnostics of young proband of 5 years old, and QTC prolongation was found just during prophylactic ECG screening before elementary school. And next one. Can you press? And here you see the ECG of this patient with really very long QT interval without any finding in all additional genes relevant for this syndrome after whole exome sequencing. And this variant is also a very good example of difficulties, what we can do when we find this such a variant. And actually, it seems that we have to introduce, or it would be very useful to introduce a risky allele category in our variant interpretation. There are only 5 classes, but there is no risky allele, but it would be very helpful for such a clinical situation. Can you press next slide, please? And now I would like to share, to conclude all these observations, I would like to share what we do with patients when we find such alleles. We do perform cascade familial screening to identify possible risk allele carriers in family members. And of course, we recommend some great caution with medication prolonging QT interval duration. we try to make informed shared decision making about sport and other high loading activity, because there is no agreements between different laboratories to include or do not include variant of class 3 into final report. Not all laboratories include variant of class 3 in final report. So there is no information for patients, and they really cannot make informed decision about their sport or other activity. And we insist that there is no any influence on reproductive decision making, because there is another problem. If you find high risky allele, patient may think, may fear that it affects somehow reproductive function and risk for children. And next slide, please, last one. For conclusion, we think that such an allele with proven functional consequences and with high representation in disease cohort should be as a risk factor allele, and this category is very reasonable, at least in long QT syndrome. It's missing category in current guidelines, and it's not easy. And taking alone without QTC prolongation, risky allele cannot serve for long QT diagnosis. And this dilemma to show up this variant or to hide it in genetic report, we prefer to show it with appropriate counseling, saying that it is not confirmation, clear confirmation of diagnosis without QT prolongation. And we found, at least in our cohort, that risk factor alleles are low penetrant and usually mild, but not negligible. At least 2 families had repeated sudden cardiac death cases. And I think we probably need a database of such a risky allele, like we have database for mutation, and it would be very helpful in many clinical situations. Again, 20% of our cohort, 18 and something, had such genetic findings. And next one. Thank you very much for your attention. I would appreciate question and probably your opinion about these alleles.
Thank you very much, Elena. Very nice presentation, including many cases. So, audience, do you have a question or a comment?
Actually, I am,
okay, yeah. Emanuela, go ahead.
I am really very much in agreement with Elena. The problem of the rare but not so rare alleles and VUS is truly the major problem with genetic counseling also in our laboratory. So I'm really very happy to hear that. I mean, because what I think is that so far guidelines didn't take in sufficient I would say importance of this issue, and I think that an open presentation of the situation is the right way to go within the family, also because a regular update of the significance of the mutation is also part of the story. So I think it is important to underline that all this is in a very initial phase and will change. The picture will change dramatically in the next few years, also with the addition of omic and all the other new genetic and metabolic approach to diseases. So I think it is very important to make patients aware of the complexity of the situation, not try to make too simple. No, I think that there was like an oversimplification, and I don't think it is appropriate at all, this attitude. The genetics so far behave as if we were looking at this as regular, like hematochemic values, like would say with glycemia or cholesterol level. It has nothing to do with this. It's nothing is positive or negative. It is much more complex. There is an interaction of gene facilitation. So I don't think that the attitude towards this entire subject has been too categorical, like something that has to do with faith, something has to have the sacro graal of the. And I don't think it is appropriate. It's a very, very wrong attitude that has really took place so far. That's my opinion. Yeah, people that think they hold the truth. I don't think it is the case. We understand, like we say, the tip of the iceberg, maybe even less than that, I would say.
Thank you. Yeah, I agree completely.
Okay, so other questions or comment? No? If not, I will move on the next topic. Thank you very much for Elena. Nice presentation.
Thank you for invitation.
Okay. The
So
second speaker. Okay, Emanuela.
It's me.
The second.
Okay, so I'll try to make it.
I think. Sorry to interrupt. I think there was a question on the chat.
Ah, okay.
Sorry, I can't hear. Can you? Oh.
Should I discuss the question or just have a written answer? How we behave? There is a question. Yeah, there is a question.
A written question.
Yeah, about routinely G.TC measurement instead of QTC in patient with BBB. Left and right. Yeah. Okay. Well, not always. Not always. To be honest, we should, but not always. Yeah. Not routinely. Not routinely, but.
Okay. So, no questions. Okay, let's move on to the next topic. Thank you very much, Elena. The second speaker is Emanuela Locati from Milan, Italy. Her talk title is ECG in long QT syndrome beyond long QT interval. Could you share your slide, Emanuela?
Yes, I am trying to share the screen,
okay.
But I don't understand why it doesn't do what I need.
Just open the, I think, PowerPoint.
Okay.
Yes, yes.
Okay.
Yeah, we can see. Yes, yes. And the screen show.
Okay.
Okay,
that's my pleasure, and I think that Elena presentation couldn't be a better introduction for my topic as well. I think it really fit well. I just want to focus a little bit on what it is the QT interval and why it is modified. Everybody knows about this. The cardiac action potential indeed is very specific and very much important in relation to the role of the heart, which is the contraction. So we don't have to forget that the two processes, electrical, electromechanical process, are well connected, and this is truly a masterpiece of nature with this interaction of ions, the flux of sodium ions and influx of sodium and calcium ions, and the efflux of potassium ions is what regulates the entire process. So this complex combination of events that occur in the cardiac myocytes, it is really what gives the entire story of the heart function. it is also important to remember that there are many, many different channels that must interact with different roles. And the timing is also very, very important in terms of activation of current that are voltage dependent. And this eventually will give rise to what we see on the surface, which is the QRS and T wave and also U wave complex. So giving this background, all this is regulated, as I said, by several ion channels, which are indeed regulated by the activity of several genes. And these, the abnormality of these genes eventually is what lead to disease state that create a perturbation of this of the regular function of the contraction and excitation. So initially that was only thought as a channelopathy, but the more and more we see, we understand that there are also mechanic alteration that we are at the beginning of the story to understand. So it is more and more, these are cardiomyopathies rather than pure channelopathies. And we have also to remember that it's not only ventricle, there are also the atria and the expression of genes, which is also changing in the course of life. So several genes are activated through embryonal life, and others are activated during young childhood and then adulthood. And several genes are related to the activity of the different component of the electrocardiogram. And so what is really important for the QT, which is the repolarization phase, are like genes that are listed here, like the SCN5A, KCNQ1, KCNE1, and also other genes, as you see. The expression of these genes is different, as I said, in different by gender. It is affected by age, gender, embryo, endocrinological and neuromodulators, and also other metabolic situations. So it is a very complex interaction that really contribute to modify the landscape. What is important is also that there is a very major overlap between syndromes. So related to the function of this channel, there are situations that the abnormalities, mutation, the single gene may give rise to very heterogeneous phenotype that would eventually are the diseases. For example, this is very true for SN5A, as everybody knows, because loss of function mutation can give rise to diseases that are known under the names of Brugada, but also they can give rise to situations such as the short QT syndrome, and rather an increased function of this gene can give rise to one of the forms of the long QT syndrome, which is LQT1. Instead, the LQT3, sorry. Instead, abnormalities in the potassium genes, in the potassium regulated channels, are those that are involved with the LQT1 and LQT2 diseases. So actually, under the names of long QT syndromes, there are very, very different nosological entities with the different genetic background and different behaviors. So we are more and more aware of the situation. But what is important for the congenital or idiopathic, as you want to call it, long QT syndrome, is that there are, we could say, two main families of diseases, one related to the sodium handling and the other that are much more common related to the potassium handling. And within the families of the potassium handling disease, there are those who are related to IKR dysfunction, which is the channel that activate earlier during the plateau phase actually stopping, concluding the plateau phase, and the IKS instead that are later in the course of the action potential, so in the terminal phase. And this is also reflected on the EKG modification that we see on the morphology of the QT interval, as we will see later. So these are the general concepts that has to be kept in mind. As I said, a mutation on the SN5A can really give very different phenotypic situations, such as Brugada on one side rather than long QT3 on the other side. Mutation of the eye carrier is usually a loss of function situation. And this is also important, as we see, with the concept of the reduced repolarization reserve, which was a concept developed by Roden, and I think it is a very interesting way of seeing things. What we see altogether is a diminution, a reduction of the net repolarizing current, so which is also called as a reduced repolarization reserve. This is the main concept behind, if you want, long QT syndrome. So there are different situations linked to the function of the channel, but basically what we see is a prolongation of the action potential duration. This can be either in the entire heart, or maybe, which is a new concept which is surfacing now, in some part of the heart, more evident than in others. So it is heterogeneity that can be seen as a regional heterogeneity rather than intramural heterogeneity. And this dispersion of the duration is eventually will lead to a dispersion of refractoriness, which favor the occurrence of arrhythmia. That might be due to re-entry or even to arrhythmogenicity, but what is important is this concept of heterogeneity of the action potential duration. So, given this frame, also with going back to the concept that we heard also from Elena before, as I said, within the families of LQT1, the distribution of the different variants is not homogeneous, with a prevalence of potassium handling abnormalities. So this is basically the situation so far in terms of genetic background in long QT syndrome patients. So a very small proportion of patients with SN5A, the LQT3, LQT1 and LQT2 basically sharing the same proportion, and then about 1/3 or maybe more, as much as the new information start to surface, of genotype unknown, and a few with genes that have been proposed but not so strongly supported by evidence, but still very interesting, and we will see more in the future about this. And as I said, the other important concept is the overlapping between these syndromes. One of the first features that really struck us in the understanding and the development of the understanding of long QT syndrome was the extreme heterogeneity of the QT presentation. So not only the QT is prolonged, but is also morphologically affected. And this information came much earlier than genetic. So we really could see there were something much more important than QT prolongation alone, because there is the morphology of the repolarization, which is heavily disturbed. And also other features were present, such as the T-wave alternans, as shown in this slide, that often preceded the occurrence of arrhythmias. So given this in mind, which came, as I said, much earlier before, that was clearly very ominous, if you want, signal. So if you could even avoid the measurement of QT interval in this kind of patient. They were so abnormal that it was not even necessary to measure the QT duration. But we tried to really quantify this project, and it was something that happened in the 90s, if you see, that we tried to really to study and to find a reason, I mean, a basis for this extreme abnormality of the electrocardiogram. And it was only when the genotype information came to our understanding that was a little easier to classify and reason on the different morphology we were able to see. Basically, we were able to, if you want, classify patients according to the morphology. So broad-based QT, T wave with a clearly prolonged QT interval, but also with not so abnormal morphology, if you want, is more usually linked to LQT1. And LQT2 is like an intermediate form, and LQT3 was characterized with a very prolonged ST interval with a very late T wave. And then there were several other forms that we were unable to classify, but still, I mean, this concept of genotype-specific QT morphology really started to emerge in this picture. And it was interesting also to observe that patient with the recessive form, so that had two copies of alleles, these two mutant alleles, tended to have a much worse phenotype than patients with the autosomic dominant forms, such as LQT2 and LQT, the Romano word forms, not Gervais, Lange, Nielsen. And it was also evident that the QT duration was in some degree related to the malignancy of the disease. So patients with life-threatening events, the recording of torsade points tended to have longer QT. But the situation was not so easy because there were other factors that seemed to be important beside the duration of the QT itself. For example, it was evident that there was a different triggering factors in the different forms. Almost opposite picture in terms of LQT1 having events during activity and exercise daytime, rather than LQT3 having events at nighttime and without a connection with exercise. By the way, this is the same behavior that you would observe also in Brugada syndrome. So it seems that LQT3 does not so much have to do with the sympathetic activation as the other forms, such as LQT1 and LQT2. The other point was that LQT2, at the difference with the other forms, tended to be occur more in a specific phase of the life, more often in women and more often during, for example, postpartum phase or pregnancy, where hormonal, if you want, turbulence is likely to occur. And by the way, it is, we will see this later, it was interesting to verify that these forms, the LQT2 mutation, are also those more often implicated in the acquired QT forms due to drugs, to several different kinds of drugs. So it is evident that these are diseases lumped under the names of long QT syndrome, but are very, very different diseases. So as this is only actually a summary of what I was saying. So drug support for LQT1, LQT2 more drug, noise, and like metabolic factor and endocrinological and hormonal factor, and LQT3, all the other side, rather sleep, rest, and nothing much related to the sympathetic nervous system activity. And this is also mirrored, if you want, exactly, but what you can see when you exercise, so when the heart rate increase. in the case of LQT2 patient, the heart rate increase really prolonged the QT duration in terms of no lack of shortening, while in LQT3 there is a normal shortening during exercise, during increase in heart rate. So these are really opposite behavior. And so this was one of the features that we explored, and we explored this very well with the Holter, which creating a family of heart rate allow the possibility to study QT dynamicity. And QT dynamicity is still not so well understood in long QT syndrome, not so well used as it should, but it is a very clear fingerprint of this disease and the different genotypic forms of the disease. So it's a genotype specific dynamicity for long QT syndrome. And what we were able also to show, I don't know why it's so sensible. Okay, is that the QT behaves in different ways in the different syndromes in terms of daytime and circadian modification. So the LQT1 has longer QT at the daytime, as you expect, and shorter QT at the nighttime, and vice versa. LQT3 has shorter QT at the daytime and much longer QT at nighttime, almost having to do with the vagal activation rather than sympathetic activation. So these are important features that should help us to characterize and to make clinical diagnosis in this patient. And also another point is one of the possibility to ameliorate, if you want, the diagnosis is the possibility to use drugs such as epinephrine to verify whether there is a marked QT prolongation during the infusion of phenylephrine. And this, you see that, for example, in a patient with LQT2, epinephrine is able to elicit exactly what you would expect in IKS mutation, such as this. So late component of the QT is emerged with the phenylephrine infusion. Okay, so not only heart rate modification, because the heart rate is not so much modified, but it is really also the reciprocal relation of the drugs. The QTC peak interval is clearly increased. So there are the other, okay. So you would, in fact, for what I say, expect to see different also in the reaction to drugs. And indeed, it was true to see that only LQT1 and LQT2 had really a beneficial effect of beta blockers that were able to reduce the events occurrence by almost by half, as you see, a favorable effect that is not observed in LQT3, where there is no favorable effect, if anything, even worsening in some cases. And if you look at the QT dynamicity, it is very interesting to see that the more evident prolongation at the daytime rather than nighttime. So the QT is longer, tendenциally longer at short RR, at fast heart rate. And this kind of cluster of prolonged QT at shorter cycle length is abolished by beta blockers. So the beta blockers really normalized these, like you say, butterfly modification, completely disappear with beta blockers. So the beta blockers have a possibility really to eliminate the QT prolongation at fast heart rate. And on the other side, mexiletine, which is a pure sodium blockers, was able to shorten the QT in this patient with LQT3. And the same effect can be seen by the QT-RR adaptation. So the prolongation of the QT interval, more evident as much as RR interval prolongs, are abolished by mexiletine. So These really help us to understand better what happened in this patient. So you have a much a better grasp on the phenomenon of the QT adaptation by Holter monitoring. And also the initiation of torsade de pointe. It is much less pose-dependent in LQT1, exactly as you would expect, and is much more pose-dependent in LQT2, which behaves, and in LQT3, which actually have like an intermediate concurrent events, parasympathetic and sympathetic activity seem to lead. And in a much more recent reanalysis of the genetic and EKG modification, this concept of the genetic specific, if you want, QT modification was really confirmed. So in much larger population, the same concept seemed to strengthen and to reemerge. Okay. One important concept, though, is that the spectrum of the QT prolongation is very wide, also within gene carriers. And this is something we still have to understand more, because first of all, the QT duration is not fixed status. As I said, there are many factors that might modify it. So you could observe a patient with normal values that moves along this scale in different phases of life. And also, as I said, there are possibilities really to trigger, to elicit the QT prolongation, such as epinephrine, as I say, also study of the QT, not only at baseline, but also during Holter monitoring. So there is a degree of overlapping. And this is also true in the acquired form. So individual exposed to triggering factors such as drugs or hormonal state may show a major QT prolongation, or maybe alteration in the electrolytes, such as low potassium for different conditions such as vomiting and so on. But the people with almost normal range of QTC duration don't have a zero risk for event. They could develop event if exposed to factors that, as I say, might be metabolic, maybe having to do with their mental state or stressor of different origins. So it's more important the genetic background that the phenotypic of the QT alone to stratify patients. So this is a very important concept. And just to show a case, this, for example, is a patient, a very special patient, showing a situation like one of the shown before by Elena. So is a patient that have variant SN5A and KCNH2 mutation. None of these mutations are considered pathogenic. So this patient has been considered non-affected by other centers. But when we studied this patient in a deeper degree, and basic also having to do with the fact that he belonged to a family with sudden death cases, you see that it's not so easy to classify a patient like this, because if you only look at the baseline electrocardiogram, it's almost like a short QT rather than a long QT. Okay, everybody would agree that he has a very normal QT on a baseline. Also, it's very bradycardic and normal QT. But when you exercise very simply this patient, when you study this patient during Holter monitoring in his regular life, you will agree with me that this is not at all a normal repolarization with a prolonged QT. In fact, what happened is that this QT does not modify at all. So what is almost normal at baseline with the normal heart rate, if you exercise during his time in his life, you will come up to a QT. Okay, with a QT which is well above 500. So it's important not only consider a patient at baseline, but also to see how he behaves, how his QT is handled during heart rate modification. So, as I say, imagine what can happen to patients like this exposed to any kind of this very endless list of medication. So it is important to consider that patients live a complex life that can take leisure drug if they are young, or they can exercise, have difficulties in their diet, etc. So it's very important not to be too like simplistic, as I said before, in their analysis in patient carrier of VUS mutation, because they could be stressed to a degree that where a major QT prolongation can emerge. And as I said, this has a lot to do with hormonal factor, of course, and this was known since many, many years. And this is particularly true for some specific variety of genes, such as the potassium handling gene, that have been strongly, in fact, linked to modification of the potassium handling by the channels. And as I said before, this is the concept of repolarization reserve that have to do basically with the IKR and IKS current. So it's very important in this kind of patient to be extremely careful in the administration of drugs that could really modify the potassium handling reserve. As I said, this could highlight or disclose the QT prolongation. And there are other diseases that could be or happen at the same time. Some renal diseases that can also provide a link towards QT prolongation, such as the Bartter syndrome and the Gitelman syndrome. This is a patient with Gitelman syndrome where there are very, very low level of potassium due to this loss of potassium by the renal. And this is a patient that seemed to be normal at baseline, but when it is unable, if you want, to shorten the QT during the Holter. You see how much prolonged is the QT in this subject simply by an increase in heart rate, and then you see also the occurrence of arrhythmia starting to occur in this patient. So it's very important to consider the dynamic of the QT in these particular patients. And this can also be true for patients exposed, for example, to high dose of diuretics that might come up to the same picture of very low potassium level in the heart, in the body. And this could really lead to arrhythmias. So just to conclude, there are clearly several different, I would say, diseases included under the name of long QT syndrome. There are some that are related, two main groups, the potassium and the sodium. They really behave differently. This can be mirrored by the QT duration on the surface and exercise EKG. So they could have very different also trigger in their in terms of the event. And so it is important to study the patient in terms of their dynamics of the QT interval. And this is also important, the need to reevaluate patient in the course of their life, and to also consider the use of drug as a possible trigger for events in this patient. So I really thank you for all your attention, and I open for discussion now.